This is Transparency, a podcast by Gender Dysphoria Alliance, hosted by Aaron Kimberly and Aaron Terrell. Each week we'll be joined by people who have personal or professional experience with gender dysphoria and physical transition. We'll also discuss how our trans experiences relate to the concept of gender identity. Join us for a compassionate yet heterodox approach to the question of trans.
All right, welcome back to Transparency, everyone. We've got my co-host Aaron Terrell back this week. How are you feeling, Aaron?
A lot better, much better. Thank you.
Good. Our guest today is Dr. Ray Blanchard. We've been really looking forward to this conversation. Is it okay if I call you Ray?
Yes, please do.
Ray's one of our advisors for the Gender Dysphoria Alliance. On topics that he's researched, and he's a professor of psychiatry at the University of Toronto, and probably best known to our viewers for his two-part typology. And that's what we wanted to talk to you about today, Ray, was just to better our understanding of the two types of gender dysphoria that you were seeing and that you were researching. So that's where we'd like to dive in.
Okay, I can talk about that. I started working at a gender identity clinic in 1980. And at that point, in 1980, many clinical researchers had written the opinion that there was more than one type of gender dysphoria or more than one type of transsexualism, however they were talking in those days. So there was, even in 1980, there was no question that transsexuals were not a homogeneous monolithic group, that there were different kinds. So I didn't bring anything new with that. The question in 1980 was, well, okay, fine, there's more than one kind, but what are those kinds? And when I studied the writings of previous clinicians, some people had 3 types, some people had 2 types, some people had 5 types. The labels were different. The type of transsexual that was nominated as the quote unquote true transsexual was different from one clinician to another. So the task I set myself was, all right, is there a way to examine the different possible different types of transsexual and narrow them down to basic categories that might look like more than, and well, let me just leave it at that. I wanted to find out, in this chaos of so many different transsexual types, what were the basic kinds? And so I started and I was focusing at that point on male to females, because in those days, female to male transsexuals were relatively homogeneous. You hardly saw anything but female to males who said, I want to become a man and I want to have a relationship with a woman. That was the overwhelming majority of those cases. So I focused my research on the biological male cases, because that was where you saw this huge variety of presentations. And that was also where the clinical literature had postulated many different classification schemes. I just began by saying, well, I used something that was from one of the early typologies from Magnus Hirschfeld, the guy who invented the word transvestism. And so I divided the biological males into homosexual according to biological sex. When I say homosexual in relation to transsexual, I mean you're interested in the same chromosomal sex as yourself. So in Hirschfeld's typology had been homosexual, heterosexual, asexual, and bisexual. So my strategy was to divide the biological males into these 4 groups and then compare them on a variety of variables. And my conclusion from that was that they boiled down to 2 basic types. One we might call homosexual, and one we might call non-homosexual. The non-homosexuals were the heterosexuals, the bisexuals, and the asexuals. They were more similar with regard to age at presentation, with regard to early childhood signs of cross-gender identity, with regard to acknowledging some history of sexual arousal with cross-dressing. So I said, okay, these three groups, asexual, bisexual, and heterosexual, these are really subtypes of heterosexual transsexualism. And these guys are all different from the homosexual transsexuals who presented at a very young age, who rarely gave any self-report that seemed like sexual arousal with cross-gender ideation. Then my next question was, well, what do the three non-homosexual types have in common? At that point, the only language or the only conceptual apparatus that would have been available to say this is what these three groups have in common was what was called fetishistic transvestism. Some history of sexual arousal, meaning quite simply in a male, erection and masturbation, or maybe spontaneous ejaculation. That was how somebody might have characterized the three non-homosexual groups in 1980. By the end of that decade, I felt that the concept of transvestic fetishism was not only too narrow, but that it actively misled people in thinking about the phenomena. And so I developed the concept of autogynephilia as something that would include transvestism, but was a much broader category of sexual arousal that a biological male feels when seeing or thinking of himself as being a female. And that was what I thought. This is your common denominator of the three non-homosexual types. It was the common denominator of the three non-homosexual types, and it also linked them to those cases that might be called transvestites, traditionally called transvestites, who only get cross-dressed or are interested in seeming feminine during states of high sexual arousal and otherwise switch back to being like men. And then there was the one final point I want to make about why I introduced the concept of autogynephilia, not only because it linked the non-homosexual types, but also because I thought there needs to be a bridge between patients who at the age of 8 or 12 or 14 are borrowing their mother's panties, masturbating, and then putting the panties back and returning to life as a boy who does normal boyish things. And then 30 years later, they're presenting with a request to have their penis removed and replaced with a neovagina. And so the other function of autogynephilia was to be, what is the link between masturbating in women's underwear at one stage of life and wanting your body surgically operated on to simulate a female phenotype at another stage of life? Just looking at underwear or females' garments didn't make a very good link. But whereas the idea of being sexually aroused by the idea of being a woman makes the link from eroticizing clothing to a foundation for wanting a woman's whole body. So that, in a nutshell, is why I started the typology and what the main outlines of it are.
Because you had divided AGP into separate groups as well, like partial AGP and what you touched on, that the target of arousal isn't necessarily the body being female in all cases, but I think I read that those that do fantasize about having a female body are more likely to want the medicalization later.
Yeah, that was one of the studies I did during that late 80s, early 90s period. And that's basically a formalization of common sense. You know, if the hottest thing to you is putting on a bra, well, then all you have to do is put on a bra. If you're really hot at the idea of having women's breasts, then you need to have surgery to get women's breasts.
Go on.
No, go ahead.
I was just going to say, one thing that comes up to mind for me, and I think when I was first kind of reading about the typology, specifically autogynephilia, is the connection between being aroused and masturbating to the idea of being a woman, and then subsequently having surgery to essentially eradicate that sexual component of it. Those, I think that's a leap that's very difficult for people to make. The autogynephile who seeks orchiectomy and vaginoplasty, it seems to me even counterproductive. But oftentimes, a lot of them find quite a bit of relief and satisfaction in having that surgery. I think there's also a high regret rate. But I was wondering if you could talk about that a bit. Is the like how does one go from being aroused, masturbating, to the idea, and then once you've had SRS, that eradicates that ability, right? It kind of eradicates the sexual component of it all, which is the catalyst. Maybe I'm misrepresenting there, but if you could talk about that.
Actually, the point that you're raising was one that I thought about and worried about a lot at the time that I was working on these problems, because it does seem very paradoxical. If you're sexually aroused at the idea of being a woman, then what happens when, by surgical and hormonal means, all sexual arousal at the thought of being a woman is eradicated? Shouldn't you stop wanting to be like a woman? That worried me. And there had been clinical notions at the time that are in line with the concern you're raising. Some clinicians had said, well, the way that you need to do a differential diagnosis between a transvestite and a transsexual is to give them estrogen. If this is a true transsexual, they will still want to be they will still want to transition. If it's only a transvestite, then giving them medications that lower libido will eliminate the gender dysphoria. So people thought that way. And I think all of that, you have to get past the idea of thinking of sexually motivated behaviors as behaviors that are accompanied by an erection. Because, in real life, there's a constellation of behaviors that have to do with reproduction. They include getting sexually excited, getting an erection, wanting to have something like intercourse, or stimulating your penis in a situation that is like intercourse. But regular sexuality also includes falling in love and pair bonding. And people do not have an erection every time they're in the presence of their wife, or they don't lubricate every time they're in the presence of their husband. And I think it's important to understand that when we talk about a behavior being erotically motivated, it's a shorthand way of indicating something that's in the reproductive sphere of human life, and that something can be rooted in that part of life, but doesn't mean that you have to be in a visibly sexually excited state all the time. And I made the analogy in some of my earlier writings that an autogynephile does not have to be sexually aroused all the time when they're being female, just as pair-bonded animals, pair-bonded geese don't copulate continuously, and men and women who have deeply committed pair-bonded relationships are not having intercourse twice and three times a day. And that was how I saw that what seems to be a paradox here really, in my opinion, results from too narrow a concept of what behaviors should be classified or identified as erotic.
Makes sense.
I hope so. I think it's a difficult concept. Well, that's all I'll say about it. I'll let you continue.
Well, it's something that came to mind as I was reading a Reddit post recently by a young, what I would classify as AGP. He was basically saying, hey, is this weird that I really want to be a woman, and then I get off and suddenly I don't care about being a woman anymore? And I think, and obviously that's kind of characteristic of the autogynephile MTF experience on a really simplistic level, right? But so my when you carry that thought forward to the logical conclusion is like, okay, so post climax, that's the same as post orchiectomy. It's like, it seems to me like once in a lot of cases, once that surgery takes place, that that's the same thing as the post climax state of the eradication of the motivation. But I think what you're saying also is like, if somebody who's had that pair bonded relationship with their not alter ego, but like their female self, let's say, you know 20, 30 years, that kind of emotional romantic attachment is more vital than the actual physical sexual component of it, in which case, a complete surgical intervention could potentially make sense. Certainly if there's significant dysphoria at the genital region, which is often, as I understand it, in the case of autogynephiles, kind of progresses into later life, is oftentimes the and again, tell me if I'm completely off the mark here, but in the younger AGPs, it's more about kind of living the fantasy, but then as the body continuously contradicts that fantasy, that's where the dysphoria sets in, where the natal sex, like having a penis and testicles and other kind of things that signify a male body, cause great distress and dysphoria, and then eradicating those that cause dysphoria is maybe more of a motivator than the sexual gratification of having a vagina.
Yeah, I agree with what you're saying. And people it's been known for a long, long time, for many decades, that the autogynephilic type of gender dysphoria tends to be a progressive condition. It's very common that with a biological males, it starts out with basically as a masturbatory activity, which more or less ends after ejaculation. But as the male ages, then thoughts of being a woman, thoughts of wanting to be like a woman start to occur outside of periods of strong sexual arousal until the person begins to think of himself as a woman all the time, sexually aroused or not. And autogynephilic gender dysphoria is very different from homosexual gender dysphoria in this way, in this characteristic of being progressive throughout somebody's 20s and their 30s and their 40s, getting more and more gender dysphoric until you start having guys. Well, I remember when I first started working at the gender clinic, they had just approved for surgery a male to female who was over 70 and who first made an effort to obtain sex reassignment at about the age of 70. Now, that's an extreme case, but the point here is that this is progressive. Autogynephilic gender dysphoria tends to be progressive. That's wildly different from homosexual gender dysphoria, which, if anything, it probably maxes out for a lot of people by puberty, and then many just adapt to their anatomic sex. So homosexual gender dysphoria is almost anti-progressive. It tends to dissipate on its own in many cases, not all cases, obviously. So it has a reverse kind of natural history from autogynephilic gender dysphoria.
Which type, thinking, putting my clinician hat on, which type do you think would be most responsive to psychotherapy? Because I guess I'm thinking about the desistance studies too, that most children with gender dysphoria would probably be the homosexual type that would desist by or through puberty, which suggests to me that psychotherapy could be helpful for that consolidation process. Whereas AGP, if we think of that as, we've been criticized in the past for calling it a sexual orientation, but I find it helpful to think of it that way just because it's more multidimensional. But I wouldn't think that could be treated or converted in any way through psychotherapy. Or have you found that there's some success in being able to change? I mean, is there any evidence that a target location error could be changed or altered in any way through psychotherapy?
Well, that's a good question. I'm afraid I have to answer it with speculation more than with facts. I need to explain that when I worked at the gender identity clinic, those 15 years, we were an agency that was mandated by the government to approve provincial third-party payment for all Ontario residents who were interested in sex reassignment. We were the only clinic in Ontario that was empowered to recommend reimbursement, to authorize reimbursement. And other Canadian provinces also sent their patients to us. So we basically were an assessment clinic. We didn't very much provide any kind of ongoing treatment, and we were in no position to provide any kind of ongoing treatment because the patients we saw were from all over Ontario, which was a big place to start with, and then all over Canada. So, I think people have the idea that we saw these patients and provided therapy to them. In the main, that's not true. Somebody might have a pet patient that they made a special exemption to see for therapy, and the patient happened to live in Toronto. But basically, we didn't do therapy. That's a long preamble to say I don't have firsthand experience in trying to somehow clinically manage autogynephilia in an adult. My suspicion is probably with the lesser gender dysphoric autogynephiles who really are ambivalent and in some moods would like somebody help them to keep a lid on it because they don't want to trash their marriage. They don't want to alienate themselves from their children. Yeah, some kind of psychotherapy could probably help people cope with dysphoric feelings, cope with controlling themselves, just as psychotherapy can help people with other kinds of erotic interests, which basically are problematic for them. So I see no reason to think that you couldn't, in some cases, help a biological male to stay in the male role and live with autogynephilia. But I would be lying if I said I have experience in doing this. And I also don't know of any systematic research that really shows that you can do this and that it will stick.
So what you're kind of saying is like therapy, or speculating on would be therapy to kind of help somebody deal with their autogynephilia in a healthy, non-life destroying way, to kind of keep it, to a private realm. But like you're not so likely would be altering that autogynephilic paraphilia, right? Like, is that possible? I guess it would be.
I don't think that you can alter any established erotic interest, but you can certainly teach people to suppress them. And I don't see much of what else you have to go with if you're dealing with people who are pedophiles, who are sexually attracted to children. If you're dealing with people who have very serious, dangerous sadistic impulses, not S&M play, but really wanting to kidnap somebody and torture them and kill them. I mean, I don't think you can eliminate these feelings, but I see no reason to think that in many cases, you should not be able to help the person control themselves if they're already motivated to try and get a handle on controlling impulses that are just going to trash their own life.
And we've been talking mostly about dysphoric males, but natal males. Is there an equivalent of autogynephilia in natal females?
That's a good question, and people have brought it up before. Okay, there are 2 points, so you'll have to remind me that I get back to both of them. One of them is, what do I think occurs in natal females, and what have other people tried to claim about natal females? There was one study. Well, I see no reason to be excessively charitable. I would call it a Mickey Mouse study, which purported to show autogynephilia in females. Somebody gave questionnaires to some small number, a few dozens of nurses, with questions that they adapted from the questions I asked biological males. And on the basis of this, they concluded that it's normal for cis, hetero, whatever biological females to be sexually aroused at the idea of being women. I don't believe that. I think that's nonsense. I think the study was very flawed. I think that, of course, biological women might have sexual fantasies. I personally don't think that there is autogynephilia in biological females. Somebody did conduct one study, which I would say is a very weak study, consisted of handing out questionnaires to a small number of women. I think it was like a few dozen nurses at some hospital. The questionnaire items were not even the same as the questionnaire items that I used to assess autogynephilia in biological males. And on the basis of this questionnaire, the author, Charles Moser, concluded that women, biological women, also are sexually aroused by the idea of being women, by the simple thought of being women. And this study is cited everywhere by trans activists as proof that Blanchard has been debunked, discredited, shown in every way to be invalid, and that, of course, women are also sexually aroused at the idea of being women. Now, I venture that if you grab the average woman on the street and said, "Did you ever get wet trying to put your panties on?" they would say no. So why did this study, which, as I said, is a pretty Mickey Mouse study, why did it achieve such popularity? Because it said something that a certain type of trans activist needed to be said. If they couldn't totally deny the existence of autogynephilia, then they had to make it something that all women have, so that a history of autogynephilia does not make you unlike a woman. It makes you exactly like a woman. So that was half of what I wanted to say about the existing evidence, whether or not women have autogynephilia. I don't think that they do. And I happen to know that there are some researchers who have a study in the pipeline, which essentially would be a replication of the one study I just told you about. But knowing the research is probably done a lot better. And I expect it's going to show that women do not become sexually excited by the simple thought of having breasts or a vagina, or knitting, or cleaning the house, or being called ma'am, or any of the things that are arousing to autogynephilic men. Now, the other variant of your question might be, do biological women have something that's analogous to autogynephilia, namely the thought of themselves as being males? And I also, now here I'm on less firm footing by far, because when I worked at a gender clinic, we didn't see very many biological females who said, "I want to become a male and live my life as a gay male." We only saw a few in the 15 years I was there. And I don't know if I even interviewed either of them, but my colleagues did, and my colleagues were good interviewers. And the feeling I got from, discussing the cases was they weren't so much interested in just picturing themselves with a penis and being excited by that. They seemed to be interested in the idea of being a gay man and of having gay sex with other males, which seemed to me a little bit different from the autogynephilic case. And so my short answer is, I don't think women either have autogynephilia, nor do I think they develop, or very many of them develop, an exact analog of autogynephilia, arousal at the mere idea of being men. I think there are some who develop erotic arousal at the idea of being gay men and having sex with gay men.
So in that case, the erotic target would still be another human being. They would have genuine attraction to gay men, whereas with AGP, the erotic target is their own self or their own body. Is that the primary difference?
Yeah. I mean, I think, sure, a lot of autogynephiles, gender dysphoric autogynephiles, describe themselves as lesbians, but I think that's secondary. I think what you start with is, I'm sexually attracted to women. I'm sexually attracted to the idea of myself as a woman. What do I do with that? Oh, wait, I'm a lesbian. That's perfect. They're sexually attracted to women and they are women. That's what I am. I'm a lesbian. But I think the I'm a lesbian is kind of a resolution of the conflicting impulses of wanting to have a woman and wanting to be a woman. I don't think that's the case with the biological females. I think with them, they start with the idea of homosexuality between men is hot to me, and I'd like to participate in it as a male. As I said, I don't have a lot of experience with those cases, but that's my impression, that there's a subtle difference.
It does kind of go back to kind of female sexuality being more kind of relational and socially based, and male sexuality being more object oriented.
Yeah, that you're right. It does fit in with that. I hadn't thought of it that way. I should mention that, less people, because people often fantasize what I and what my gender clinic was like back in the old days. We did the two cases I can specifically remember who presented during that time, clearly stating that they felt that they were gay men and wanted to become gay men. We did approve surgery for both of them. And as far as I know, they both did fine after surgery. But these patients had been living as men, and they were sexually experienced with men and sexually experienced with men who were willing to engage with them sexually as if they were two gay men. So these were not naive teenagers who are sitting in their bedrooms and developing some fantasy of, oh, gee, I think it would be cool to be a gay man. These were individuals who had walked the walk. They had lived as males. They had been sexually experienced with males. They knew what they were getting into. They understood what the parameters were before we approved them for surgery. So I think approving those cases for surgery was the right decision. I think, however, among this new contingent, the rapid onset gender dysphoria kids, I have the impression some whack of them are girls, teenage girls, who have the idea that it would be cool to be gay men, but these girls do not have a real life experience of trying to live as males or of trying to find gay male sexual partners who are going to regard the absence of a penis as an unimportant detail, like somebody having the hair color that you don't prefer. I wanted to make that point because I thought, a lot of people are going to say, oh yeah, but yeah. There's lots of girls presenting now who want to become gay men. And why shouldn't they? And I think that the positive experiences of my clinic with these kinds of cases really don't bear on teenagers who have no experience of living in the world as men or of trying to find sexual and romantic partners among gay men without a phalloplasty, or with a phalloplasty, which is not going to pass muster among connoisseurs of penises, which gay men are going to be.
What were you finding the ratios to be between the homosexual type and the non-homosexual type?
The last time I looked at that, I don't remember when I published it, back in the 80s, I guess. At that point already, there were more of the autogynephilic type of male patients than the homosexual type. It was maybe like, 3-2 or something. Now I suspect the ratio is much higher. In those days, a biological male had to give up a lot to pursue life as a woman. Divorce was essentially inevitable. Alienation from children occurred in a large proportion of cases. Of course, patients went into this hoping that their wife would say, okay, now you're a woman, I still love you, and we'll live together as two lesbian women, and fantasies that their children would get on board with it. But in many cases, that didn't turn out to be true. So there were, and also, there was more social stigma. Now, to use the cliche, coming out as trans in middle age when you're already a husband and father is, quote, stunning and brave. And people laud the patient and kind of ignore the wife and children. So I think that with the social stigma being reduced, that there are a lot more of the autogynephilic / non-homosexual patients presenting, whereas the number of the homosexual cases has remained pretty constant.
It almost seems to, it's not even just a reduction of stigma. It's glamorized and kind of, and as you said, lauded to a capacity like over just being a straight man. Right. In many circles, certainly in progressive circles, it's like that's a way to elevate your status, coming out as trans. It's it's seen as some like a kind of a purity. You're no longer a straight white man. You're the most beautiful and marginalized of lesbians. So it has not only is there no stigma, or obviously there's still plenty of stigma in certain quadrants of society, but in our blue spheres, it's quite celebrated. And then on the flip side of that, I think it's even more dangerous when we're talking about the young people getting swept up in it, because right now in online circles, it's and even real life circles, it's there's vilification and stigma in being cis and straight, right? And so young people are doing anything that they can to opt out of that. I'm going in a different direction here, changing the subject a bit, but yeah, it seems to be like with the demographic that you would have been seeing in the 80s, it's kind of flipped on its head as far as what you're losing and giving up when it comes to transition, and obviously the vast majority of people are heterosexual, so we're going to see this the numbers are going to be even more misaligned, or not misaligned, but more skewed in the direction of non-homosexual transsexual than they were 3 decades ago.
Yeah, I agree with you. And, a lot of the work I did on typology really doesn't apply to the ROGD, the rapid onset gender dysphoria kids, who I think are probably a very mixed bag, which might include some who would have been diagnosed as classical transsexuals whenever they presented. But there's also a large proportion, maybe a majority of kids who basically have personality disorders, adjustment disorders. Maybe they're just terminally silly, who would not have been, covered by the typological work that I had done back in the 80s and early 90s.
When we talk about gender dysphoria, one of the things that I've found difficult to understand is whether we would consider, if you think of gender dysphoria as like the hub of a wheel, like are there different pathways to this thing called gender dysphoria, or do you see these two types as completely different and unrelated to one another?
I see the two classical types as converging on extreme gender dysphoria and the request for surgery and hormones to change the body. For that reason, I never the clinicians before me were all very invested in which type is the true transsexual. I mean, a lot of ink was spilled over which type is the true transsexual. And, there would be these kind of competitions, amongst different psychoanalytic writers, my type is true. No, my type is true. I never used that terminology. I can appreciate why a lot of people would see the homosexual male to as true, because they just feel different, from the autogynephilic type. They feel more feminine. But my way of looking at it was once you reach the maximum level of gender dysphoria and the same range of clinical solutions is available, that they're equally true. Now, I'm not sure how that answers your question. I think that when you look at those patients, they still have a flavor of where they came from. Just like, somebody who was born in France speaking English has a different accent in English than somebody born in Germany speaking in English has. And I think you can think of it that way, that transsexuals retain the accent of where they came from. But I resisted the idea that clinical decisions should be based on that rather than on intensity of gender dysphoria and the best available solution.
Because even with the with autogynephiles, at the point at which they may come to a clinic saying, I want to actually change sex, it's not necessarily sexually motivated at that point, is it? I mean, it could be that the actual distress about their body, which we would call gender dysphoria, has progressed.
This gets back to what I tried to say before is, how do you conceptualize what is sexually motivated?
Right.
We think of it as sexually motivated is what a guy is experiencing when he's got an erection. And, I think we could say it's based in sexual motivation. Maybe it becomes something else. Does it 100% lose all of its ties somewhere in the depths of the brain to sexual orientation? I don't know. Probably not, but
it's a misconception with the homosexual subtype as well, because both of these types are linked to sexual orientation in one way or another. I remember I did an interview for Rebel News a while ago, and when that was posted to their Facebook page, in all the comments underneath was like, keep it to the bedroom, as if all of this is just about, a kink of some kind, even the homosexual subtype of gender dysphoria. What would you say, what is the developmental pathway for gender dysphoria in the homosexual subtype?
I guess I think of the homosexual subtype as basically they start out as sissy boys or tomboy girls who, unlike the majority of people in that class, do not normalize in gender identity when they hit puberty. So I think what you could say with the homosexual type of biological males or females, it's not so much that they develop something new as it is that they don't shed something that many other seemingly similar kids shed as they hit puberty or their teenage years. For them, it's a continuation of behaviors that were present from a very young age.
I know when I've searched through my own memories and trying to articulate my own experience of gender dysphoria, as a young child, because we get into so much trouble when we try to find words for something that doesn't really make sense to most people. And then we've attached to certain words so much, like this idea of a gender identity, for example, that we've called it that, and we've attached to that idea to the point where we almost believe in this sort of gendered soul, is how the narrative is spun off of that. But I think a better way to describe what I experienced is like a cognitive categorization error, that I just had so many natural boyish tendencies that in a naive young mind, I just kind of categorized myself as male. And I can understand how, as a person gets older and you're integrating more sophisticated information, and then your sexuality wakes up, that categorization error would correct itself unless something is disrupting that. Would you agree with that use of like a cognitive categorization error in the homosexual subtype in the case of like a sissy boy or a very masculine girl?
Yeah, actually, I do think that something like that exists. I don't think it's necessarily conscious. I don't think it's necessarily formulated in words, but yeah. I think with the young kids, at some level, there is what you call a categorization error. And I think that probably is maybe one of the few really useful uses of the phrase gender identity, is when you're talking about kids who are so young that that what you observe is that they're systematically imitating members of the opposite sex and not members of their own sex. And I think their gender identity is a useful concept to explain why, when all the other kids are imitating adults of their own sex, is this kid imitating adults of the opposite sex. I think the word gender identity is useful in that context. Now, gender identity has so many other meanings. It's become a replacement for biological sex and this and that unfortunately, it's become a phrase that probably creates more misunderstandings than clarifications. I know that towards the end of the period when I was doing a lot of writing in this area, I began avoiding using the phrase gender identity in my writings, and I talked instead about gender dysphoria, because I thought, well, I know what gender dysphoria is. You know, you can, if somebody comes in and says, I'd like my penis removed and replaced with a vagina, please, I could say, yeah, it's pretty safe. This person has gender dysphoria. So,
I mean, as you are well aware, I mean, the whole narrative around this has changed so much over the last 40 years. You know, and now we just call it all trans and it's all the same, and that we all have the same kind of gender dysphoria, and there's simply just different sexual orientations of trans people. Why do you think the topology is important? Why do you think it's important to retain that information, that there are actually different types of motivations for transition?
I think it's important for two separate reasons. I think it's important for science. If you're interested in someday finding out what causes gender dysphoria, you have to separate your cases into ideologically homogeneous groups if you're going to get anywhere. You know, if you have some idea that you're going to find some part of the brain that looks like it's shifted in a cross-gender direction in transsexuals, well, you might find it in one category of transsexuals, but not in another. So for scientific purposes, I think it's essential that you be able to classify patients according to etiology or probable etiology. And saying this is not novel to studying gender identity. People who study any kind of behavioral or psychiatric or psychological condition have to begin by diagnosis and by separating apart cases that might seem superficially similar because they present with the same spectacular symptom, but probably got there by different means. So A, we need typology for research. B, for prognostic purposes, I think it could also be relevant. I did one study on regrets in postoperative. I think they were all postoperative, male to females, and I found a slight tendency for the non-homosexual / autogynephilic types to have more second thoughts about transition, and I predict that with a group that was less highly screened than ours was, you're going to see eventually a lot more cases reverting to the female role who are coming from the autogynephilic camp. So in terms of prognosis, which is a clinical issue, not a research issue, it's a practical issue. I think it makes sense to say, this is a patient of this type, and maybe we should be just a little teeny bit more cautious in this case because they have a higher rate of second thoughts, or in the worst case scenario, detransitioning.
Yeah, it's remarkable to me the number of there's a therapist out of the UK. I forget his name, but he said he's seen a number of autogynephile post-operatives who have regret about their surgery. They often, obviously, they didn't have the surgery in the UK. They went to typically, I think, Thailand to have it performed. But he's seen quite a number of this cohort, and I see similar posts on social media and stuff in detrans spaces. People have expressing extreme regret over having SRS, male to female transitioners, and it's remarkable to me how many of them seem to not understand the fact that their desire to transition is very much rooted in their testicles. You remove that, and then the regret obviously sets in. So it's just remarkable to me that, like, I was seeing a post of this male to female transitioner who had an orchiectomy, and he was saying that he basically was really surprised after the fact that he no longer, basically his girlfriend still wanted to have sex with him, but with her, and she didn't want to anymore. Like, she had no sexual response. Basically, it was like, have I made this huge mistake? And just the utter confusion and confoundedness that this drastic decrease in sexual response had occurred. It seems it's quite flabbergasting to me that this escapes a lot of the male to female transitioners, and it seems to be very, very modern now, rooted in the trans ideology that having these feelings mean you really are a woman, and that going in this direction is therefore the right course of action. Transitioning entirely is what you should do. So the notion that talking about autogynephilia and talking about the fact that this is where the motivation comes from, that is transphobic in and of itself, is I don't want to use the word transphobic in the other direction, but it seems to me that so much harm is being done by trying to suppress your work and the work of other people who are talking about the typology and the very fundamental difference in those two typologies. Anyway, yeah, so it just seems like so much harm is being done by the ideological framework, that it's surprising to me that individuals who are seeking those surgeries are completely, that they don't understand where that motivation is coming from, and that it's being clinically enabled by the same kind of ideological capture. Sorry, that wasn't a question. It was just a thought that got me rambling.
Yeah, I agree with you. In the old days, I know it's horrible when you get old and you find yourself saying this all the time, but in the old days, we made sure the patients understood what they were getting into. If we had a patient that really had magical thinking that they were going to really literally change sex from top to the bottom of their chromosomes, we would consider that a counterindication for surgery. We felt that patients needed to have a realistic understanding of what surgery and hormones would do and wouldn't do. And we would have thought it was a bad sign if patients didn't seem to grasp what the limitations were of the procedure. Now, I don't know how many gender clinics make that kind of appraisal or have that kind of concern about their patients.
What you were saying about, the value of the typology, one of the values is being the science. I've noticed a lot of like MRI studies, they're trying to find that holy grail, right, of some biomarker for transsexualism. But I notice a lot of those studies, they don't control for sexual orientation. So I just wonder about the validity of any of that data then, if they're lining up just a bunch of transsexuals of different orientations and scanning their brains. I don't know, even if there was this holy grail that existed in some types of gender dysphoria, I wouldn't expect them to find that in both the homosexual and the non-homosexual types. And so I just wonder about the value of that science then, if they're not controlling for sexual orientation.
Yeah, I 100% agree with you. And when I read research that talks about transsexuals as if they were a monolithic entity and makes no attempt to specify what kind of transsexual are you talking about, I basically assume at that point that this research is going to be garbage. Now, sometimes you can tell from reading other stuff in a manuscript, oh, all these cases were of the homosexual type. They just don't say it. And sometimes you can write to the authors and find, and they will say, oh yeah, they were all blah, blah, blah. So sometimes you can salvage the data by other information that the authors didn't stress, or by writing them directly. But I agree with you. I mean, as I said, if I see research that talks about, let's say, MRIs of transsexuals and doesn't acknowledge that there are different, probably ideologically different categories, I just say this is garbage and I'm not going to concern myself with it. Now, I have a lot of other reservations with existing MRI research, one being that in other fields of MRI research, findings are overthrown quite often because people are looking at samples that are too small. So I don't know how many studies of transsexuals have been ruined because they didn't start out with a diagnostically homogeneous group, because these studies at this stage in 2021 are often too small to say this is going to be would have been a definitive study in any case, even with the most meticulously screened subjects.
There was a tweet that I read, one of yours fairly recently, that I was curious about it, and I think it was something along the lines of that the line between a butch lesbian and gender dysphoria, that line is a little bit more blurry than between the sissy boy and gender dysphoria. I just wanted to ask you about that and what you meant by that. Why that line for the natal females would be a little more blurry than with the natal males.
I remember that tweet. This was a common observation of clinicians at the time that I started working in the area of gender identity, which, as I've said, was 1980 when I got into it. And so a lot of people believed that. And it seemed it kind of made sense to me that the line was blurrier, because I knew that there were very butch lesbians, stone dykes or whatever they're called, who, when they would have sex with their girlfriends, would have rules, like they could touch their girlfriend's breast or vagina, which naturally what you would want to do during sex, but they wouldn't want or allow a girlfriend, the femme of the pair, to touch their own breasts or vagina, or they would keep a t-shirt on during sex so that their breasts were not in evidence. And these were women, lesbians, who did not call themselves trans, but just thought of themselves as butch lesbians. But this kind of behavior, don't touch my breast, don't touch my vulva, this is what you see in, transsexual females, who don't want to be reminded of their biological sex during sexual encounters with females. So it seemed to me plausible that, yeah, it does kind of look like you're seeing some behaviors in the butch lesbians that shade into the kind of stuff you see from fully transsexual female to males. Now, you could argue, well, maybe you would say that same kind of spectrum in homosexual males if you looked for it. That's true. Maybe you would. But I don't know about drag queens saying, nobody can touch my penis when I'm having sex. Maybe this exists, maybe it doesn't. I've never heard about it.
I wonder if I've thought about that. It makes sense that there would be more natal males transitioning than natal females, just in the fact that with natal males, there's two types of gender dysphoria, and AGP being the dominant one. So that alone, it would make sense that the ratios between males and females transitioning would be different. But I also wondered with the butch lesbians, if maybe part of why they didn't have the same drive to transition was because of the existence of the butch femme subculture, and if they found ways that they felt supported and affirmed within that culture in a way that they didn't feel the same need to transition. Because I'm not aware of a parallel in the gay male community where sissy boys and really masculine men that was a whole subculture in gay male culture. And maybe it exists and I'm not aware of it, but I certainly don't hear about that subculture as much as I would hear about the butch femme subculture in lesbians.
That's, my impression as well, is that within the lesbian I hate to say community, I'm just so sick of that word in general, but
Yeah.
amongst the lesbians, there seems to me, from my casual observation, to be a much stronger tendency for people to identify as femme or butch and to structure their relationships accordingly. I don't know if that exists or exists to the same extent among gay men.
Because I've heard some HSTS male to female transsexuals say something along the lines of, had I not transitioned to female, I probably wouldn't have found the partner I really wanted to partner with. That they really wanted to partner with a very masculine man and have what they would consider a sort of a normal white picket fence lifestyle, and they didn't feel that as a very effeminate gay man that they would find a suitable partner and have the lifestyle that they wanted. Would you say that theme is something that you observed in your research?
Yeah, this is a point on which Mike Bailey and I have had some back and forth. Not really so much a disagreement in substance, but moreover a disagreement in emphasis. I think that, clearly, the male to female transsexuals of the homosexual type, for prospective partners, they want heterosexual men. They don't want gay men. And so I think it's easy to make a jump from that and say that the homosexual male to females transition in order to attract heterosexual men. I think that's too strong a formulation. I think it's undoubtedly true. Yes, they want heterosexual men, but I don't think that they do the surgical and hormonal transition for the sole purpose of attracting heterosexual men. I think they mostly do it to feel more comfortable in society. And, some of them are just so feminine that no matter how hard they tried to butch it up, it wasn't going to work. So they make a kind of calculated decision. Well, I can't butch it up, so I'll go the whole other way and be a woman, and this will make me, I'll come out the other end as normal.
Yeah, that's a helpful clarification.
And I also want to point out, which people tend to, when people talk about this, about homosexual male to females wanting heterosexual male partners and putting a huge emphasis on that, I want to point out something that, is often overlooked. Transsexual homosexual males are not the only ones who find heterosexual men hot and would like to get their hands on them. So this desire or attraction, preferential attraction to heterosexual males is not a clear diagnostic indicator of gender dysphoria in a homosexual man, because it's not unique to transsexual homosexual males.
It's because it's more like, it seems that within gay male spheres, masculinity and heterosexuality in men is actually quite favored, right? So it seems like masculinity is the is sought after, femininity not so much. Whereas in the case in lesbian communities, masculinity is celebrated, unlike femininity in gay male communities.
My impression is that, as the two of you have already pointed out, that masculine gay men are much more prized and much higher in the hierarchy, much more desired as sexual partners than feminine gay men. Now, there might be some guys who like effeminate partners. I don't know. My feeling is that that they're at the bottom rung, and if they are defecting to become female to male transsexuals, nobody would be bemoaning the fact, because they were below the waterline anyway. They weren't what people were looking for sexual partners. So it wouldn't be the same sense of our community as being eroded the way many lesbians feel about the wholesale conversion of butch lesbians to becoming female to male trans. I don't know how that translates into social engineering. I mean, I think it's very difficult to establish something like a societally accepted third gender as they have in Samoa or other places in the Far East, maybe not as formalized as the Samoan Fafina, but other places in the Far East where there's a recognized social role for effeminate males who basically are dressing as women most of the time, but without surgery. I think it's hard to take those kinds of social structures and graft them onto a Western society. I don't know whether that can be done. It's a nice idea. It would be nice if it would be nice for, if butch lesbians were given a way to live that would not require hormones or surgery. I don't know if it can be done. I just don't know. And also, I think this is one of the cases where trying to talk about gay men and lesbian women in symmetrical ways kinds of breaks down for reasons as you've already alluded to. Butch lesbians are prized within the lesbian community, but feminine males are the bottom of the heap in the gay male community. So it's hard to formulate some kind of abstract solution that applies to both male and female homosexuality because they're not symmetrical all the way down the line.
Yeah, that's a good point. Just on the topic of the gender critical folks, what would you see as the primary difference between your concept of gender dysphoria, the research-based concept of gender dysphoria, versus the gender critical concept of gender dysphoria?
Well, partly because of my background, I guess, I basically see gender dysphoria as a type of mental disorder. Now, people, of course, just freak out at that phrase mental disorder, and immediately they think it means you're barking mad and are hearing voices and think that somebody is putting microphones hidden around your house and whatnot. But actually, there are all sorts of mental disorders that can be quite circumscribed in their effects and leave people with average or sometimes very superior ability to function in other spheres of life. So I want to be clear that, although I don't want to, obfuscate my language by piling euphemism upon euphemism. So I'm going to say mental disorder, but what I mean by mental disorder does not mean you're absolutely, totally crazy all of the time. It could just mean some particular psychological trait that needs special consideration, special accommodation. So my conceptualization of trans phenomena is that it's basically a mental disorder, which if it cannot be treated by other means, can be palliated by having the person transition to the opposite sex by the use of surgery and hormones and by some reasonable amount of social accommodation. But my starting point is mental disorder, and you look at everything as flowing from mental disorder. The gender critical folk, I think in a weird way, have adopted the same approach as the trans activists in that they only want to talk about socio-political phenomena, and neither group talks very much about the psychiatric causes of gender dysphoria. So, I see gender critical people writing tweets in which they are, in so many words, or clearly asserting that autogynephilic transsexualism is the result of patriarchy, sexism, and misogyny. I think that that's completely wrong. It's a complete misunderstanding of what gender dysphoria in autogynephilic males is about. I think that gender critical feminists talk this way because they're not interested in what causes gender dysphoria. They're interested in the effects of gender dysphoric males on their lives, on women's lives. And from the standpoint of a gender critical feminist, the effect of having, let's say, an autogynephilic husband is the same as the effects of other kinds of abuse caused by sexism, misogyny, and patriarchy. But I think that they are confusing cause and effect, and they're never going to understand what autogynephilic male to female transsexuals are all about if they just keep reusing the conceptual entities they're used to, patriarchy, sexism, misogyny, and try to apply them to males who have motivations and a psychology that's really entirely alien to women.
It's a good point. I mean, it's certainly, as a researcher and a clinician, it certainly isn't your responsibility to work out everything downstream, all of the policy and all of the sociology of this. When you said reasonable accommodation for transition, I mean, what that means is probably different from environment to environment, and needs to be negotiated probably quite individually. But I wouldn't expect you to have all the answers about everything that happens downstream and how we organize our culture around this. I mean, you're just researching, well, what is this clinical phenomenon?
Yeah, well, I mean, I did do some work on trying to see that the patients that we approved for surgery were doing okay. I mean, I couldn't, although my personal interest was in what used to be called descriptive pathology, I couldn't just totally blow off my responsibility as a researcher working in a gender clinic to see how patients were doing who underwent sex reassignment or social gender reorientation. And I did grind out a bunch of papers in that regard. And I found what everybody else found, which was that the majority of patients who were properly screened said, yeah, I'm glad I did it. I feel better and I'd do it again.
What did proper screening look like?
It was pretty rigid with us. We required that the patient live for 2 years as the opposite sex before they were even considered eligible for being approved for surgery. And during those 2 years, they had to either work or attend school in the cross-gender role, or if they were really elderly, then we would require them to do something else, like volunteer for some charity and do their volunteer activities in the cross-gender role. And we would require them to provide us with documentation. So if somebody said, yeah, I have a job now and I'm now working as Mary instead of Martin, they had to prove to us that they were employed as Mary and not as Martin, so that, you couldn't have a patient just stay in their apartment and order pizza delivery and say, well, I'm wearing a dress and I'm now living as the opposite sex. They had to prove that they were living as the opposite sex. This had a couple of I've supported this very strongly in my clinic for a variety of reasons. One was that we had various psychiatric consultants who worked there, and I would see that sometimes clinicians brought their own idiosyncratic views as to whether a patient was appropriate, whether a patient was really transsexual. I think I worked with really, really good psychiatrists. I respected all of them, but some of them would occasionally bring in their, like I said, their own idiosyncratic judgments. And sometimes you get patients who are really hateful, miserable people. There's no two ways about it. The fact that they're transsexual is kind of ancillary, and you don't like patients who are unlikable. And so I thought, I very much supported the idea of the real life test because this was objective. The patient was doing it or they weren't. And I thought that it helped eliminate the subjectivity of psychiatric judgment. That was one reason why I supported it. Another reason was the diagnostic impact. To some extent, it screened out the more intensely gender dysphoric from the less intensely gender dysphoric. It also, just being gender dysphoric does not mean that you're going to hack it in the cross-gender role. It just means you would like to. If the patient lives in the cross-gender role and provides us with the documentation, we have proof that they can make it in the cross-gender role. I don't think this means that they were literally fooling people about their biological sex, because in many cases, patients had good jobs and they stayed in the job they were already in and just negotiated with their employer that they were now going to come in as the opposite sex. So passing as the opposite sex in the sense of literally fooling people was often not even an issue. They had to prove that they could be accepted as the opposite sex well enough to maintain a job, to go to school, to live their lives. And there's a fourth reason, which I didn't talk much about in the old days, but that was that you had to be fairly psychiatrically stable to go to school for 2 years or hold a job for 2 years as the opposite sex. This is not only true of transsexuals, this is true of other people. You know, one of the main symptoms you would make in diagnosing somebody as having a serious mental illness is that they're unable to maintain any kind of stable employment. If all you know about them is, geez, here's somebody who has normal intelligence, a decent education, no particular obstacles to them, and yet we have an employment history that consists of bupkis, you know, with one short-term thing after another. So it screened out people who were not going to be good examples of post-operative transsexuals to the world at large. You know, and I didn't used to talk about that at the time because it sounds like, well, your duty is to the patient, you know, and I kind of thought, yeah, our duty is to the patient, but our duty is also to this patient population. And it doesn't do this patient population any good if we're cranking out people who are getting into horrible messes and even worse, into the news after being approved for surgery. So the fourth reason for my liking the real life test was it not only tended to screen out those who weren't gender dysphoric enough, but it screened out those who were going to be bad poster children for transsexualism.
One of the biggest things that's changed, you know, in the activism is, I think 30 years ago, even 15 years ago, when I first started this whole process, we retained our understanding of our own biological sex, and that seems to have eroded and changed over the last 30 years. That where people seem to be really pushing this idea that that they truly are the sex that they wish to be. You see people posting all the time or talking about that they really are, that literal sex change is possible. Do you have any thoughts about that change, you know, from a psychological point of view? Do you think there's value in people retaining the idea that I am a transsexual, I am, you know, natally male or natally female? Because because gender dysphoria in itself isn't a delusion, and it's in the scientific literature, it's never been called that. But it does seem almost like almost the creation of a delusion that this narrative that is now being taught to young people. Because when young people are coming to gender clinics now, they're not being taught your typology; they're being taught, you know, the queer theory narrative, and that they're truly trans, and yes, we can do the sex change. Do you have any concerns about that change in narrative and the impact that might have on patients?
Well, I think there has been a change in narrative, and the two of you, you know, also other Aaron T, you know, might want to comment on it. It's hard for me to say to what extent the change in narrative is because people are feeding each other quasi-delusional notions over the internet, and to what extent is this just a kind of calculation that a more realistic narrative is not going to play with the general public, and we have to push a version of transsexualism that's going to play with the general, that's going to work with the general public. So it's hard for me to separate out those two things because, I'm not in the trans community. I'm not trans. I don't know. I think certain aspects of being realistic would not be good PR. Everybody says, and I, to some extent, I agree with this. If people were more open about autogynephilia, they would be happier, and maybe not go as far in reassignment as they do. But I think you have to ask realistically, how many people in the general public would accept an honest explanation of autogynephilia, and somebody being honest and saying, I'm an autogynephile and here's what's hot to me sexually. Would they be amongst the general public applauded for their honesty and their ability to handle their own emotions and look at them objectively? Or would people just say, well, it's all very well that you're being honest about your feelings, but my God, you're disgusting anyway. I mean, I think it's some of what the trans activists are doing. I don't like it. I don't agree with it. I don't think you can indefinitely enforce contrafactual notions on the general public, but they might not be entirely crazy that some kinds of truth are not palatable to the general public.
Yeah, I can certainly understand, trans women going to work or dropping the kids off at school or something don't necessarily want the whole world to be looking at them and thinking of them as an autogynephile. So I can understand in terms of the, as you said, the PR of it, I think makes sense, but it concerns me to the degree that the clinicians have lost the understanding of the clinical aspects of this, in an evidence-based, because I mean, the PR and the politics shouldn't creep into the clinical world to the extent that clinicians are denying the science.
Well, I don't think politics have crept into the clinical world. I think they have completely seized the clinical world. Yeah. It's been total ideological capture. Now, as I've indicated from earlier, I mean, I've been out of that world of away from frontline clinical treatment. I don't know who the people are who now work in gender clinics. I expect they're very different people. In my day, the people who worked in gender clinics were mostly highly trained, either psychiatrists or psychologists. Most of them didn't do gender full time. They mostly had other kinds of patients whom they saw. They had a rounded experience of working with psychiatry patients, psychology patients with a variety of disorders. I kind of think that there are not a lot of people now who are called gender specialists with God knows what kind of credentials, who probably are not well-rounded in terms of handling psychological problems in general. And so I don't know what they think.
I think a lot of it's also been kind of self-select, like since the ideological takeover. A lot of the kind of equipped and ethical clinicians, such as yourself, Aaron, have kind of like, well, I got to get out of this, and are not actually working with the population anymore, just because of the fact that the ideology has crept in so far. So you see a lot of the kind of qualified clinicians moving out because they just cannot ethically do it, and a lot of quacks essentially, filling that void. And so the other thing I wanted to say was I think so much of that, the ideological capture is kind of enabled by concept creep of language. Going back to what you were saying, Aaron, about the whole notion of like a literal sex change, or that if you say that you're a trans woman, that means you're literally female. I think so much of that is not. It's obviously a misuse of the word literal. I think it's almost like it's just a capture of language more so than a capture of the actual of what we're describing. I think so much of this is about, if you refuse to use the language that validates an identity, then you are somehow, morally in the wrong. And so so it's not. That's what I guess. I don't know where the delusion begins and where just a force of like language begins. It seems so much more rooted in kind of making sure everybody uses the appropriate designated language to keep the validation train moving, and less so really thinking about the details of what's being said. Like the actual reality of male and female seems, it's just kind of taken a back seat to the constant validation of overtaking language, even including biologically male and female language.
Yeah, I'm sure that the language is part and parcel of the reformulation of what the patients are, what their condition is, and what the best solution is. And they certainly have the trans activists who are pushing that. And I'm kind of like beginning to think maybe I shouldn't be calling people like that trans activists, because who's a trans activist, right? It's not like you get a certificate. And and I think there are probably a lot of people who think of themselves as trans activists who, are just keyboard warriors. But I forget where I was going, but they certainly are very invested in preserving the language that's being used. And that's for reasons that have been discussed by much smarter people than me about how different kinds of political movements, totalitarian political movements, have to restrict the language as a way of restricting thought, trying to restrict the words that are available so that they make it harder to think certain thoughts. And I certainly believe that is an element of what's happening.
And I mean, going back to, the understanding that the average autogynephile wouldn't want, their teachers and coworkers to know all of the details of their sexual fantasies. But I do wonder about, and I don't expect you to have an answer to this. It's sort of musing that I wonder about the impact on the young people not having an evidence-based understanding of what they're experiencing. I mean, it's all a big psychological and social experiment, really, because young people who are transitioning now aren't being. I know I would have benefited from your typology earlier in life, just for my own processing and understanding what my experience was and making sense of that. And young people today aren't being taught that. They're being taught, well, you're just a trans person. I mean, we all know what that narrative is, right? That's queer theory based politicized narrative, where we're not giving young people the opportunity to really understand what they've experienced. And we really don't know what the long-term mental health outcomes of that will be.
No, but I think they probably won't be good. I don't
think so.
I don't think you can take a heterogeneous population like the rapid onset gender dysphoria. Let's just leave aside rapid onset gender dysphoria. I don't think you can take a heterogeneous population like teenagers with gender dysphoria, give them testosterone or estrogen after seeing them once or twice, and think that everything is going to be okay. I don't get it. And I think there's going to be a lot more cases of detransition and regrets. And all one can hope for is that the detransition cases are ones who stopped with hormones and didn't go for surgery, because the surgeries are irreversible,
So yeah, it's a fear shared by many, just what the long-term consequences of this is going to be. Well, thank you so much. I don't want to keep you longer. I'm sure you're a busy man. But thank you so much for agreeing to come on the podcast and talk to us. It's been helpful for me to hear from you and be able to ask some of the questions that have been on my mind.
Well, it was fun to meet both of you.
Thank you very much.
Thanks for joining us for this episode of the Transparency Podcast. If you enjoy our content, please help out our algorithm by hitting like or subscribe. If you'd like to make a donation, follow the link to our PayPal account. On behalf of the Gender Dysphoria Alliance, thanks for your support.